Welcome back, everyone. We're going to continue our advanced pharmacology series with talking about medications for airway and ventilatory management. As a reminder, medications discussed in this lecture are intended to provide a brief overview of the common medications in the noted area and are for education purposes only. Please remember that allowed medications, their specific doses, indications, and uses will be subject to individual states, EMS services, and medical control physicians. Always follow your local and state policies, regulations, guidelines, and protocols for specific medications in your service area. All right, starting off with a bang, let's talk about some of the most important and most dangerous medications for airway and respiratory management. This group of medications that we're going to talk about is the class of medications noted as paralytics. Paralytics work by sweeping the synaptic cleft from acetylcholine and binding to the acetylcholine receptor sites and preventing stimulation of any of the ACH receptors. This causes the inability for a patient to move any of their skeletal muscle and can help facilitate intubation in patients that we can't get a tube through or we can't intubate because of a clenched jaw or a tight airway or just an inability to access that airway. This provides a more facilitated approach to intubating a patient through orotracheal intubation and helps prevent damage from forcing an intubation on a patient that is not paralyzed. Understanding that paralytics, when administered, are neither sedation nor pain management and should not be given alone. A patient who is administered a paralytic simply cannot control their skeletal muscle or their diaphragm. The patient is still conscious, the patient is still awake, and the patient can still experience pain. These medications should only be utilized to facilitate intubation in conjunction with the appropriate sedation, preoxygenation, and drug-facilitated intubation or rapid sequence induction series to facilitate the intubation of that patient. Don't forget pain management as well. Just because a patient is adequately sedated and paralyzed doesn't mean they can't experience pain. Okay, looking at our two types of neuromuscular blocking agents, or paralytics as they're more commonly known. The two types of paralytics that we deal with as paramedic providers in EMS are depolarizing paralytics and non-depolarizing paralytics. Succinylcholine is the only depolarizing paralytic that we use. When we refer to the term depolarizing paralytic, we mean that the receptor sites are depolarized. You'll see faint muscular contractions as the medication begins its onset, also known as fasciculations or tremors across the body. In younger patients, these can be somewhat violent and resemble a small or short duration seizure. And sometimes you may see just small fasciculations of the eyelashes or the arms or legs may just tremor slightly. The non-depolarizing paralytics don't depolarize the neuromuscular joint, and therefore no fasciculations are noted in those patients. The table on your left is a common set of doses seen across EMS as paralytics are concerned. Understanding that these doses may vary widely from service to service, and your ability to use paralytics is going to be dependent upon your state and local regulations, policies, and protocols. For succinylcholine, the typical dosing is 1 to 2 milligrams per kilogram via IV push. One thing to note about the depolarizing agent is they're relatively short-lasting, with the non-depolarizing agents being longer-lasting in duration. Vecuronium and rocuronium are two of the common non-depolarizing agents. The medication dosage for VEC is 0.1 to 0.2 milligrams per kilogram, with a maintenance dose needed about every 45 to 60 minutes. With rocuronium, it's 0.6 to 1.2 milligrams, and the dosing period will vary depending on the patient as far as a redose is concerned. Looking at succinylcholine, it's competitively binding with ACH. It's not affected as quickly by acetylcholinesterase, and succinylcholine is the only depolarizing paralytic that we discuss in EMS. Fasciculations can be observed during its administration, And this was what I previously described as small or fine muscle tremors that are noted across the body after administration. Understanding that the depolarizing neuromuscular blocking agent, or succinylcholine, has a very rapid onset of total paralysis, but also has a very short duration of action. Because of the depolarizing nature of succinylcholine, it comes with a long list of contraindications, potential side effects, and caution. You should use caution in any patient that has increased intracranial pressure, increased intraocular pressure, patients with burns, crush injuries, blunt force trauma, patients with glaucoma. And you should also use it in cautions with patients who have a history of malignant hypothermia or belong to the Lumbee Indian tribe. This can also cause significant bradycardia with the muscular fasciculations, as it can stimulate the vagus nerve, which can subsequently cause additional vasodilation and bradycardia. The non-depolarizing neuromuscular blocking agent binds to the ACH receptor sites, but doesn't cause depolarization of the muscle fiber. So for these medications, you don't get the fasciculations that are seen in succinylcholine. And as mentioned earlier, the two most common are vecuronium and rocuronium. Other medications that are used in respiratory management include beta agonist medications. Albuterol, which is a selective beta-2 agonist that is typically nebulized. We can also use levobuterol, which has similar effects to albuterol, but with fewer beta-1 effects. We also may administer terbutaline for its respiratory implications, as well as racemic epinephrine, and racemic epinephrine is nebulized. Mucokinetic and bronchodilator medications. The most common that we see in EMS is ipratropium bromide. Ipratropium, or Atrovent, antagonizes the muscarinic receptors. It causes bronchodilation and decreases mucus in the upper and lower airways. This medication is not given by itself. It's typically given with albuterol in the composition known as a duoneb, and helps facilitate the mucus movement in patients, particularly with asthma and COPD, and then helps facilitate the effects of the bronchodilatory effects of albuterol or other bronchodilator medications that are administered. Other medications used in respiratory management include corticosteroids, the most common being Solumedrol. Solumedrol reduces airway inflammation and improves oxygenation and ventilation. Need to use in caution in patients who are immune compromised, as steroids have immune suppressant properties, and there are many contraindications and adverse effects to the use of Solumedrol. One thing that's important to note, there is a mentality in some areas of EMS that we don't need to give steroids because the mechanism of action or the onset time is far exceeding the time that we spend with the patient. But that's not really good practice with medication administration. We give the medication sooner rather than later, so long as it's indicated, so that not that we can see the intended effects on the patient, but so that the patient experiences the relief provided by that indicated medication sooner rather than later. We should never withhold a medication from a patient because we won't see the intended effects during our time with the patient. At the end of the day, it's the patient that matters, not the provider.